Perfect. Hi, good morning, everyone. I'm just going to let everyone into the meeting and then we'll start in a second. Lovely, thank you. Good morning. We've still got a few people just coming into the meeting, so we'll start in just a second. Lovely. I think we've got about 90 still just filtering their way in. I think Teams is being a little bit slow with the warm weather this morning.
I've never had it such a slow countdown before, but at least it makes us look really popular.
Yeah, absolutely. I'm conscious of not leaving anyone behind, but the number is dialing down.
I'm having to admit everyone individually. I tried clicking the admit all and it didn't seem to work. So I'm just working my way down, clicking ticks to admit people.
That's all right. I'm doing the same. Right, I think we're nearly there. 10 left. Morning, Sandra. Thank you. Okay, I think we've got everybody. So good morning, everyone. Thank you very much for joining us. My name's Sarah Wheeldon. I'm a haematology consultant at Royal Devon Next Hospital and NHSBT. And it's my pleasure to welcome you all on this beautiful but very hot morning. And I'd just like to start by encouraging everyone to have a large bottle of water next to them as we go on with our morning. We've got a really fantastic lineup of speakers today and hopefully something for everyone. I've just got a couple of housekeeping points. There's a Q&A function, which hopefully you can see on Teams. So please put in there any questions that you've got. And if we have time at the end of each talk, we'll try and answer a question or two. If you don't have the Q&A function, you're welcome to put things in the chat. Everybody, I think, will be muted for the duration of the session, just so that we don't have any interruptions, but hopefully your camera function is enabled. So if anyone does feel happy to put their camera on this morning, it's really nice for our speakers to be able to see some faces. If you have any IT issues, then Samia, who's our excellent administrator, her email address is there. So please drop her an email and we'll do our best to sort things for you. At the end of the session, you will get a link inviting you to give some feedback. We'd be really grateful for your thoughts on the session, and then you'll be sent a certificate after that. This is our schedule for the morning. We'll take a short break after a couple of hours and then hopefully draw things to a close just before 1 o'clock. So without any further delay, it's my pleasure to introduce Dr. Emma Saunsbury, who's a consultant hepatologist here at the Royal Devon University Hospitals, and she's going to start things this morning by talking to us about pathophysiology in chronic liver disease. Thank you very much, Emma, if you want to take over.
Hi, thank you so much for the invite to speak. I'm just going to start sharing my slides and hopefully that will all work fine.
Yeah, that looks great, Emma. Thank you.
Lovely. And you can see them moving okay?
Indeed.
Great stuff. So yeah, thank you so much for the invite to speak. I think the aim of my presentation at the start of the morning is really just to provide a bit of background about what chronic liver disease is, how it develops, and the implications, as hopefully that provides some really helpful context for some of the other presentations later on this morning. So thinking particularly of Professor Roberts, who's going to be discussing the tricky topic of coagulation in chronic liver disease, as well as my colleague Dr. Levick, who's going to be discussing upper GI bleeding. I'm aware that we've got quite a mix of specialties, as well as a mix of allied health professionals, resident doctors, consultants, and other clinical staff joining us today. So it's been a little bit challenging to try and work out how to pitch this presentation, but hopefully there'll be something useful for everyone. And as has been mentioned, if you do have any questions, just pop them in the chat and I'm happy to answer them afterwards. So we're going to start off just by talking about common etiologies of chronic liver disease, talking about the progressive stages of how it develops, how it then progresses to decompensated liver disease in certain cases, and then I'll finish off just by talking about portal hypertension, particularly related to chronic liver disease. So why do we care about chronic liver disease? I think this slide has been brought out for almost all presentations about chronic liver disease just because it really is so striking. So to orientate you along the sort of the y-axis on the left, we've got essentially mortality rates for different chronic conditions. They've used a slightly strange scale, comparing it to the baseline in 1970 and then thinking about how things have progressed. So you've got all the different chronic conditions moving across the right in different colours, and you can see that for the vast majority, reassuringly, there's been an improvement in mortality since 1970. However, by far the outlier is liver disease up at the top in the darker blue, and you can see that there's now been a 4 times higher difference in death rates compared to 1970. So that's a 400% rise in mortality over the last 50 years. And it's got to the stage that liver disease is actually the leading cause of death of those aged 35 to 49 in the UK. So an increasing problem that unfortunately we're seeing more and more of. So what do we actually mean by chronic liver disease? It can be really complicated in hepatology because there's lots of different terminology. When some people talk about chronic liver disease, you'll also hear terms like chronic liver failure, advanced liver disease, and cirrhosis. Essentially, what we mean by chronic liver disease is something that's effectively progressively affecting the function of the liver, causing it to deteriorate over a more than 6-month period. So it's not an acute process that resolves within that time. The process of chronic liver disease essentially involves progressive inflammation and destructive of the liver parenchyma, so the liver tissue, which leads to fibrosis, which is liver stiffening, and eventually sometimes liver cirrhosis, so scarring of the liver. And I'm going to talk about that in more detail over the next few slides. The main thing to take away is that chronic liver disease isn't synonymous with cirrhosis. So cirrhosis and liver scarring is the final stage of a chronic liver disease, but not everyone with chronic liver disease will have cirrhosis. There are lots of different conditions that can cause a chronic liver disease, and we're going to talk about those next. So I'm just going to pause for a second and ask you to think to yourselves what conditions would affect the liver and potentially cause a chronic liver disease. And I'll give you a few seconds to think about that. I think for most people, your mind probably would have gone to alcohol, which is not surprising because it is the leading cause of chronic liver disease in the UK and in many countries across the world. However, coming up as a close second is something called metabolic dysfunction associated steatotic liver disease, or MASLD, which is far less of a mouthful. And this is essentially related to metabolic risk factors. So things like being overweight or obese, having type 2 diabetes, having high blood pressure, or having high cholesterol. It used to be called non-alcohol related fatty liver disease, or NAFLD, but there's been a change in nomenclature over the last couple of years. And the reasoning behind that was essentially because patients with alcohol use disorder experience a huge amount of stigma anyway, and sort of classing something as alcohol related or non-alcohol related was really not helping with that. So it's been a really positive step forward changing that name. It used to be quite complicated because a lot of patients had lots of metabolic risk factors that would explain their chronic liver disease, but they also drank heavily as well. So we were never quite sure what to call that because saying they had alcohol and non-alcohol fatty liver didn't really make sense. So as part of the nomenclature update, we've developed a new condition or new terminology, and that's something called METALD, so metabolic dysfunction and alcohol-associated liver disease. So these liver conditions make up a big part of our workload at the moment. In terms of other potential causes of chronic liver disease, you've also got autoimmune conditions. So you've got PBC, primary biliary cholangitis, PSC, primary sclerosing cholangitis, AIH, autoimmune hepatitis. You also have viral hepatitis, particularly hepatitis B and C is what causes chronic liver disease. Various genetic conditions also need to be considered, so hemochromatosis resulting in iron overload, Wilson's resulting in deposition of copper within the liver, and alpha-1 antitrypsin deficiency, which is an enzyme deficiency affecting the liver. Moving into the slightly more rare causes, drugs can also result in chronic liver disease, particularly traditionally things like nitrofurantoin as an antibiotic. You can get vascular conditions, so Budd-Chiari is when you get a blood clot affecting the hepatic vein. And then rarely, you can also get something called cryptogenic chronic liver disease, where we're not able to exactly determine the underlying cause. So how do these actually affect the liver? Well, the sort of first process in specific conditions like the MASLD, METALD and alcohol-related liver disease is that the liver goes from being a nice sort of healthy liver to developing a buildup of fat within the liver. The process of that developing is actually relatively complicated, and to be honest, it could be a talk in itself. But just to give a broad brush sort of summary, so thinking particularly about MASLD, so those metabolic risk factors, due to your risk factors of obesity, dyslipidemia, you start to develop insulin resistance. And that sets off a cascade of things like lipogenesis and lipolysis, which essentially results in free fatty acids and a huge buildup of triglycerides developing within the liver. And that's what gives you your fatty liver. Because that fat's not meant to be present in the liver, it starts to irritate the liver tissue, leading to mitochondrial dysfunction and oxidative stress. And that leads to a degree of inflammation within the liver. And that's when we start to develop hepatitis. That irritation process then can develop even further to start to build up something called fibrosis, so stiffening of the liver. And that, again, is relatively complex in all the different pathways that are involved. But to keep it nice and simple, it basically, a lot of it centers around hepatic stellate cells. So these are cells within the liver parenchyma which proliferate and differentiate into myofibroblast-like cells, which lead to deposition of collagen and other extracellular matrix components within the liver tissue. And that starts to cause the liver to become stiff and develop fibrosis. It's worth mentioning that for other liver conditions, so for those not related to alcohol or fatty liver, you don't get that fatty liver stage. The process of fibrosis develops directly, so you go straight from having a healthy liver to just developing that inflammatory process and the liver stiffening. It's also important to recognise that this isn't necessarily something that will just continue progressing, and there is actually a chance for regression and actually, in fact, resolution of fibrosis. So as you can imagine, that can only happen under certain circumstances. So if a patient, if for example, a patient has hepatitis C and we're able to successfully treat the hepatitis C, or if they do have fatty liver but they're able to lose weight or optimize their diabetic control, then you can the liver can start to regenerate and you can go back to having a healthy liver, which is obviously what we love to see when we see these patients in clinic. However, unfortunately, in some situations that isn't the case, and that fibrosis and the deposition of sort of stuff within the liver continues, and that's when you start to develop actual cirrhosis. And essentially with that, it's due to increased development of connective tissue within the liver. You get a restructuring of the liver and vascular system with disrupted architecture and sort of essentially aberrant hepatocyte regeneration. That leads to nodule formation within the liver. And once you get to the point of that nodular scar tissue, so cirrhosis, unfortunately, that's essentially a point of no return where you're never going to go back to having a perfectly healthy liver. One thing that also becomes relevant when patients actually develop full-blown cirrhosis is that there are increased risk of developing cancer within the liver, so hepatocellular carcinoma, and that's just due to the increasing DNA damage that develops. So that's a bit of a whistle-stop tour through how chronic liver disease progresses from a healthy liver to the final stage, which is the development of cirrhosis. So sometimes it can be relatively easy to diagnose cirrhosis, and that can be due to a combination of blood test results, clinical signs, or imaging. but sometimes it can actually be less straightforward. And we also find that patients can have possible cirrhosis overcalled. So for example, they can have an ultrasound which shows an irregular liver edge, which people often think is definitive for cirrhosis, but it's not always the case. The only way to be definitive in these situations is to do a liver biopsy, but that's obviously relatively invasive and associated with lots of risks that we'd rather avoid. So a great tool that we now have in our arsenal is something called a FibroScan, which is a non-invasive way of assessing liver stiffness. As you can see here, it essentially uses a transducer probe that's a little bit like an ultrasound, and it's placed between the ribs, but it uses shear wave technology. So sound waves pass into and back from the liver using a little transducer. I sort of explain it to patients. It's a little bit like the starter mechanism of a pinball machine. So they get a little kind of flick against their abdominal wall, and that gives us an idea of liver stiffness. It's not perfect, so the results can be falsely elevated in the context of obesity or with significant alcohol excess, but generally it's relatively good. This is just a slide showing how we interpret the results of FibroScans, and I'm not expecting you to take absolutely everything in from this, but just to orientate you, at the bottom you've got the liver stiffness measurements in kPa, ranging from 1, which is minimal, to up to 75 is the highest range. And then you've got the different etiologies of underlying chronic liver disease. Thinking about the different colour bars, so on the left we've got F0 to F1 fibrosis, so either no fibrosis or just a little bit. And then as you progress through the colours all the way through to the purple on the right, that's when you've got significant sort of advanced fibrosis or potentially even cirrhosis. And I just wanted to highlight this because the underlying etiology depends on how we interpret the results. So if, for example, you look at the bottom and you've got a liver stiffness measurement of 14 kPa, if the patient's got underlying autoimmune hepatitis, that would correlate to F3 fibrosis, so moderate fibrosis. But if you go a few up, so if the patient instead had alcohol or what used to be called NAFLD, but is now MASLD, related liver disease, you'd then be within the purple F4 category, which is advanced fibrosis or possibly even cirrhosis. So it's not a one-size-fits-all in interpreting the results. So when patients do progress to cirrhosis, they often ask about how bad is it? And for us as hepatologists, the really important thing to clarify is whether a patient has compensated or decompensated cirrhosis. Decompensated cirrhosis is essentially when the liver starts to lose more and more of its function, and there are several hallmark features of that. So one of the main things we see is jaundice, which is biochemically an increased bilirubin, but when it gets high enough, you can actually see that clinically with yellow eyes or yellow skin. Patients with decompensated cirrhosis also develop ascites within their abdomen, which is a large volume of fluids. And again, I'm going to go on to talk about that shortly. Decompensation also manifests with hepatic encephalopathy, which is a cognitive dysfunction that at a low level can just result in a reversal of a sleep-wake cycle or patients being slightly distractible, but as it progresses can result in patients becoming increasingly confused, drowsy, and in advanced encephalopathy actually going into a coma. Patients with decompensated cirrhosis also develop a degree of renal impairment, and then it can manifest with GI bleeding as well. I don't want to step on Dr. Levick's toes too much, but that can be GI bleeding from varices in particular, which develop as a result of something called portal hypertension in cirrhosis, which I'm going to come on to on the next slide. So portal hypertension essentially does what it says on the tin, in that it's increased pressure within the portal vein, which is the main blood vessel that feeds into the liver. I'm going to go through this in stages because it's a little bit of a complicated pathway, but hopefully we'll get there in the end. So if we start off with the liver in the top left, we've talked already about how the liver becomes scarred in cirrhosis, and that increases vascular resistance. So that means that blood doesn't flow through the liver quite as well as it should, leading to increased portal pressure. This has a knock-on effect of leading to increase of sort of back pressure of blood to other areas of the body, one of which is the veins in the esophagus and the veins around the stomach, and that can lead to the development of varices, so big blood vessels essentially. In response to increased portal pressure, chemicals like nitric oxide are released, which dilates blood vessels, and that affects the gut. So you get sort of vasodilation of the splanchnic blood vessels around the gut, and essentially that leads to a lot of pooling of blood within these widened blood vessels. Because of that, you get less blood returning to the heart and perfusing the kidneys. So the body gets a bit confused and starts to think it's in a hypovolemic state, even though it's not. And that leads to the activation of the renin-angiotensin-aldosterone system, or the RAS, RAAS, and that's activated by the kidneys. And so the kidneys start to stockpile salt and water because they think the body needs more water, even though it doesn't. And so it's a bit of a vicious cycle in that by drawing more water and fluid into the body, it increases cardiac output and how much blood's pumping around the body, which again further leads into increased inflow and more portal hypertension. So it's a really vicious cycle. And it's as a result of this cycle that patients start to develop not only ascites fluid in the abdomen that we've talked about in decompensation, but also varices. In my final couple of slides, I'm just going to talk about varices in a bit more detail just to orientate those who aren't as familiar. So in these photos, you're looking essentially down someone's esophagus food pipe during an endoscopy camera test. So you're looking almost like down a drain pipe. And you can see on the photo in the left that at the 11 o'clock and 5 o'clock position, you've got some slightly purplish blood vessels that are a bit more prominent than the nice pink tissue of the esophageal lumen. As you move to the middle photo, these are far more bulky and bulging. And then in the right, they're almost completely occluding the lumen. So these are really high pressure, high risk varices that are at really high risk of bleeding. And unfortunately, sometimes when patients are having an active bleed, we go down with our endoscope and this is what we see. So esophagus full of blood, and that lovely white arrow is very helpfully pointing to the bleeding source there. So you can see blood just spurting from a weak point in those blood vessels. You can also develop varices in the stomach as well as the esophagus, and this is my final slide. So you can see here that you're essentially looking up at the fundus, so the upper part of the stomach from inside. So the black thing you see is the endoscope camera, which has come through the gastroesophageal junction, has turned round on itself 180 degrees and is looking at the entry point to the stomach. And this is actually a sort of after photo of gastric varices have been treated, but you can see the gastric folds there, but otherwise relatively smooth. But this is the before photo, so this is a gastric varix. And again, you can see this big bulging, they sometimes refer to them as sort of bunch of grapes appearance. And again, these are at really high risk of bleeding because of that increased pressure from portal hypertension. And this is a bleeding gastric varix, so you can see this huge jet of blood that's sort of spurting out of it. And as you can imagine, that's an emergency that requires treatment. So that's a bit of a whistle-stop tour through chronic liver disease. So hopefully, having talked through everything, you should be able to list the common etiologies of chronic liver disease, describe the progressive stages of chronic liver disease until it eventually develops into cirrhosis, explain the features of decompensated liver disease that happens as a result of cirrhosis, and then finally explain how portal hypertension develops. Thank you very much. I'll stop sharing my slides now.
That was absolutely fantastic, Emma. Thank you very much, and set the scene beautifully for the morning. We have got 1 minute, so you're perfectly to time. And we've got a question. We've actually got a couple of questions, but if I just perhaps pick one of them, and if you don't mind, maybe looking at the Q&A and answering any others that are in there, that would be amazing. We've got a question of, do you find liver disease is more common in certain ethnic groups, particularly the non-alcoholic type, and if so, why?
I think there's a lot of evidence to suggest that there are higher risk sort of categories for people. So particularly in sort of Southern Asian population and things like that, there is a tendency to accumulate more metabolic disease. So there are trends in particular. So it's something that we do see for sure.
Brilliant, thank you. I think in the interest of time, we'll move on to our next talk. Oh, apologies, I do see there's a hand up. If whoever's got a hand up wants to pop a question in the chat, and hopefully Emma won't mind, if that's all right, Emma,
yeah,
having a little look and writing some answers, that would be excellent. So our next speaker is Professor Lara Roberts, who is a sorry, not quite sure how I got muted. So Lara is a consultant haematologist at King's College Hospital and honorary professor in thrombosis and haemostasis at King's College London, and is kindly going to talk to us about coagulation in chronic liver disease. Thank you very much, Lara.
Thank you, Sarah, for that introduction. Can you see my slides and hear me?
Yes,
okay?
Absolutely fine. They're perfect.
Okay, thanks. I've slightly changed my title, sorry, to haemostasis, just because I'm aware of it being a mixed audience and I didn't want to just talk about laboratory aspects for the full talk. And thank you to Emma. I've managed to delete a couple of my slides while you're doing your talk because you've covered some of what I needed to explain, so thank you. So I'm going to focus a little bit on this concept of rebalanced haemostasis in patients with chronic liver disease. And most of the data here actually comes from patients with established cirrhosis that I'll talk about. And then I'm going to talk about peri-procedural management. So thinking about the risk factors for bleeding, the role of any pro-hemostatic agents in this setting, and what the current guidance recommends. So in patients with established cirrhosis, one of the consequences is that we get failure of synthesis, and we know that liver is the main organ that produces blood clotting factors. So we see reductions not only in the procoagulant factors, but also in the natural anticoagulant factors, so protein C, S, and antithrombin. And we have reduced thrombopoietin, reduced Adams-13, and reductions in antifibrinolytic factors, and possibly increases in TPA related to reduced clearance. And as we've already heard, we also see patients develop portal hypertension, and this leads to both hypersplenism and endothelial activation, resulting in increases in factor VIII, von Willebrand's, and Pi1, along with thrombocytopenia and platelet activation. But when we try and measure what's happening with patients' coagulation in the lab, we commonly perform a coagulation screen and a full blood count. And we find that these patients have increased prothrombin time and lower platelets. And these tests are just too simplistic to measure the complex changes that occur in patients with cirrhosis. So just as a reminder, or for anyone who's not familiar with what we're measuring in the lab, the clotting times are a very basic test. We basically add an activator with calcium to citrated plasma, and then we time how long it takes for the first bit of fibrin to form. So prothrombin time is really only measuring very limited procoagulant factors shown here, and it's not measuring any of those anticoagulant factors or other complex changes that occur in patients with liver disease. So in particular, it's not measuring any of the cellular interactions that are really key in hemostasis, and not measuring the natural anticoagulants, which are important in regulating hemostasis in health. So there's been a lot of work over the last 20 years to look at more detailed laboratory tests to try and better understand what's actually happening in patients, not only with liver disease, but with other complex coagulopathies. So one of those tests is something called thrombin generation, which is where, again, plasma is tested with an activator, so usually tissue factor, as well, and then calcium to calcify the blood. And then you can measure the thrombin that's generated over time, so you get a more global view of clotting. And you can add something called thrombomodulin, which activates the protein C pathway, so that you also get a measure of the natural anticoagulant role in clotting. So in this graph here, just along the bottom here, the HC is healthy controls. Then we've got stable cirrhosis, acute decompensation. So these are the patients with things like ascites or recent variceal bleeding or encephalopathy. And then we've got a final entity here called acute on chronic liver failure. So these are patients who go on to develop additional organ failures from acute decompensation. They're often very ill and usually in critical care. Oh, sorry, my pointer's jumping. But if we look at sort of the assay that's really just focusing on procoagulants, so the dark squares here, you can see in those with stable cirrhosis and acute decompensation, they have fairly well preserved thrombin generation. And when you add thrombomodulin to activate the protein C pathway, they're actually hypercoagulable compared to healthy controls. And that's even true in the very ill patients with acute on chronic liver failure, where many of them still have normal thrombin generation, but with much wider individual variation. And this directly contrasts with the INR, or prothrombin time, which increases with increasing severity of liver disease. And the prothrombin time really is just a marker of liver disease severity rather than underlying haemostasis. So there's been other laboratory assays as well, looking at different parts of the clotting pathway, but they have again demonstrated that there's compensation between pro-hemostatic and anti-hemostatic pathways, so that the reductions in procoagulants sort of counterbalance the reductions, the reductions in anticoagulants counterbalance the reduction in procoagulants, along with the increase in factor VIII. The increase of von Willebrand factor compensates for the reduced platelet count, and there's rebalancing of fibrinolytic factors. But we know, as we've heard, that patients with liver disease do bleed, but it's increasingly recognised now that the majority of that bleeding is mediated by portal hypertension and the variceal bleeding that Emma was talking about. And there is concern about bleeding at the time of procedures, in part driven by these abnormal blood tests. But increasingly, it's recognised that that's largely a result of trauma rather than an underlying hemostatic problem. And patients with spontaneous mucosal bleeding and extensive bruising are actually less common. So just to further illustrate that, this is data from the PRO-Liver study. So this is an Italian study that followed 280 patients over 3 years. And they found that the rate of major bleeding was about 4% per year. And the majority of those bleeds were secondary to portal hypertension. And when you look at an ILA cohort, so these are patients from King's, it's over 600 patients admitted to our liver ITU. And we looked at major bleeding rates just during that admission to ITU. So you can see it's much higher. So 14% had a major bleeding event. But again, the majority were due to portal hypertension, with also some non-portal hypertensive bleeding. But procedural bleeding was actually relatively uncommon. So of the whole cohort, only 1.6% had procedural bleeding after admission to ICU. So just the initial take-home messages from this are that the prolonged clotting times and thrombocytopenia are not good measures of hemostasis in these patients, and that most bleeding is due to portal hypertension and not coagulopathy. So I'm going to move on now and talk about procedural bleeding risk. So there's a number of professional societies that have stratified the risk associated with common procedures. This one is taken from the European Association of Study of Liver Disease, where they defined major bleeding. They defined a low bleeding risk procedure as one with a major bleeding rate of less than 1.5%. And you can see in the table that most of the commonly performed procedures that are undertaken in patients with liver disease have a major bleeding rate of less than that. And then a high bleeding rate, they defined as a rate of greater than 1.5%, or where bleeding would be difficult to control or have severe consequences. And there are only 3 procedures here, and I think you could probably debate some of these. So dental extraction, for example, this rate is taken from one paper with 300 patients, and this is the rate of bleeding, but it wouldn't meet a definition for major bleeding in that all the bleeds were locally controlled with no one requiring blood transfusion or any other intervention. And there is variation across the societies, I think, due to this interpretation of the difficult to control or severe consequences. So particularly liver biopsy. In the American guidelines, both percutaneous and transjugular liver biopsy are considered high bleeding risk. And in the International Society for Thrombosis and Haemostasis, percutaneous is considered high bleeding risk and transjugular low bleeding risk. So there's a bit of interpretation differences across different societies. But if we look at how well our laboratory tests perform in predicting bleeding risk, this is a very old study undertaken by Professor Yu over 40 years ago, where he performed liver biopsy under direct vision and simply timed how long it took for the biopsy site to stop bleeding. And across the bottom, you've got the prothrombin time. So this vertical line here is the lower limit of normal for prothrombin time, and this is the median liver bleeding time. And you can see there's no relationship here between bleeding time and the prothrombin time. But still 40 years on, we are still talking about this. But there have been more modern studies. So this is a recent study performed by a group in France where they had over 300 patients undergoing liver biopsy. And they had sort of a stratification where if a patient had a prolonged INR, so if the INR was more than 1.5 or platelets were less than 50, they would preferentially do a transjugular biopsy, unless that wasn't possible, so if they were targeting a lesion. So none of these patients had any blood components prior to biopsy. And there was a rate of 7% of bleeding in that they could see hematoma on an ultrasound performed post-liver biopsy, but very low rates of major bleeding. So 0.6% of the cohort required an intervention. This was just 2 patients who needed vascular embolization, and one of those also had a red blood cell transfusion. Again, suggesting that liver biopsy is a low bleeding risk procedure. And in these patients, they undertook very detailed profiling of haemostasis. So they measured multiple individual clotting factors. They did a PFA 100, which gives an indication of platelet function. They measured clot lysis time, which is a measure of clot breakdown or fibrinolysis. And they did global assays, so thromboelastometry and thrombin generation. And then they pooled all of these results with a principal component statistical analysis, which is shown in the scatter plot on the right. And the red dots are patients who had bleeding on ultrasound, and the blue dots are those who didn't. And again, there's no association here between the various hemostatic profiles and bleeding. And in fact, the only predictor they found of bleeding was patients reporting pain post-procedure. And this is the biggest study that, again, was published relatively recently. This is a multi-center study in North and South America, where they recruited over 1,000 patients who were admitted to hospital with decompensated cirrhosis. And amongst these patients, over 3,000 procedures were performed. And again, you can see the rates of bleeding here. So they classified the procedures along the American classification, and 90% of procedures performed were low bleeding risk. And the major bleeding rate in this cohort was 0.9%. So again, very uncommon. And this is despite the median INR in these patients being 1.7 and 15% of patients having a platelet count of under 50. And they went on to look at predictors for bleeding, and they only identified 3, the strongest of which was the innate procedural risk. So procedures that were considered high bleeding risk were more likely to result in a bleeding event. And then body mass index, there's a weak association, and then MELD, which is a measure of liver disease severity, again was a stronger association, but no relationship again either with INR or platelet count here. And I guess important to note that patients who do bleed have poorer outcomes, so it is something that we should be aware of and try to avoid. But I'm not sure hemostatic testing contributes to that. So I always get asked about viscoelastic assays, so is TEG or ROTEM or sometimes even Quantra useful. So these are assays that can be done now nearer the bed. This ROTEM is an old analyzer. I'm sure Dr. Gorlinger will show you a more recent one in his talk. But these can be done on whole blood. They're now using cartridge-based analyzers, so anyone can do them. You just have a cartridge that you free put in some blood. It's very easy, and then you stick it in the machine, and it gives you a readout like this. Or hopefully not like this, because this isn't a normal curve, but you have various parameters depending on which test you do. The Quantra gives you a different output, but there's not as many studies in liver disease, so I won't be talking about that further. But again, you get the time to first clot formation is the R or CT. Then you have time to 20 millimeters of clot, which is K or clot formation time, and then the maximum amplitude or maximum clot firmness. And the R time really reflects the clotting factors, and the maximum amplitude is a measure of platelet and fibrinogen. and the K contributes to that as well. You also get a measure of fibrinolysis. But there are limitations to using this in patients with liver disease, in that, again, it's insensitive to the natural anticoagulants, it's insensitive to von Willebrand factor, and there's a lack of validated cutoffs sensitive for bleeding risk, perhaps outside liver transplant, which you'll hear more about later. So if we look at studies who tried to determine a threshold for predicting bleeding in the procedural setting, there are two. Here you can see they're relatively small. So compared to the PropBleed study with over 1,000 patients, we've got less than 100 in both of these, having less procedures. And the first study is looking at central line insertion, which is a very low bleeding risk procedure. But despite that, had a fairly high major bleeding rate. And they both report that they were able to find a threshold that was associated with bleeding. So if you had a prolonged K time in this study, you were more likely to bleed. Whereas if you had a good maximum amplitude, you were less likely to bleed. And in this second study, if you had a low maximum amplitude, you were less likely to bleed. And this platelets weren't predictive in this study. They didn't measure fibrinogen. And this is using an older TEG technology called TEG 5000, where they didn't have a specific measure for fibrinogen. So I don't think we fully understand what these findings mean, and they've not been further validated in studies, so certainly not ready to use. And they didn't look at whether things like liver disease severity contributed to bleeding risk. So not ready for clinical use. Oh, sorry, I don't know what that little circle's doing there, but my animation has failed. But anyway, there's also been studies looking at using these assays to guide transfusion peri-procedurally, because we know that more patients with liver disease will have a normal TEG or TEM tracing than a normal INR or platelet count. So you might reduce peri-procedural transfusion if your intention is to try and correct these parameters. And I'll talk about why we shouldn't be doing that shortly. Again, these are small studies with sort of mixed procedures, and they compared these thresholds for guiding transfusion to TEG or ROTEM thresholds, depending on which study. The study by Rocker also had an arm of sort of no transfusion, where they would only give FFP if the INR was more than 5, or platelets if they were less than 25. So you can see that using or patients allocated to the viscohemostatic assay received less platelet transfusion. So none in the Rocker study received platelet transfusion. And less plasma transfusion as well. But you'll note that if you have a restrictive policy, you can also reduce plasma transfusion. And I would suggest that for a low bleeding risk procedure like a line insertion, we shouldn't be trying to correct coagulation prior to the procedure. And I will talk more about that shortly. There are other factors that contribute to procedural bleeding risk, and these are not limited to liver disease. So things like operator experience, and I think everyone would use imaging guidance for most procedures these days. Obviously, vitamin K deficiency, if someone has concomitant infection or renal impairment, they're also recognised as risk factors for bleeding, as is the use of anticoagulant and antiplatelet agents. And there is data that if you over-transfuse, so particularly giving large volumes of FFP, that will increase portal venous pressure. So that will actually increase your risk of bleeding if you're doing procedures in that area. So things like TIPS or even variceal band ligation. So most commonly performed procedures in these patients are a low bleeding risk. And the prolonged prothrombin time and thrombocytopenia do not predict or increase bleeding risk. So if we think about interventions to target bleeding, we often see these patients being given vitamin K, but there are quite a number of studies now suggesting that that's probably not useful for most patients. Obviously, where patients are at risk of malnutrition or malabsorption, there may still be a role. But in this study, which had over 90% of patients with cirrhosis, and they looked at change in INR after 3 days of vitamin K replacement, and found that in 63% the INR did not change, and a predictor of it not changing was having cirrhosis. And I guess one of the useful things they also found was that if there was no improvement in your INR after 1 dose, it was unlikely to improve with 2 further doses. So FFP, as I said before, is often used, but we know that the prothrombin time doesn't lead to, or isn't a good measure of bleeding risk, and giving FFP increases the risk of both transfusion-associated cardiac overload and acute lung injury. It increases portal pressures, and as shown by this study, can lead to hypercoagulability. So you can see these patients were all given 10 to 15 mils of FFP, and their INR and thrombin generation was measured before and after. We used to have this threshold of 1.5, and very few of these patients achieved that threshold after plasma transfusion. And if you look at their thrombin generation, the sort of peach band is the normal range. So most of these patients had normal thrombin generation, or even increased prior to transfusion, and it increased slightly more with plasma transfusion. So if you take one thing away, this is what I would like it to be. Please don't give FFP prior to procedures to prevent bleeding. It doesn't work, and it causes patient harm. So there's less data for platelet transfusions. It's a small study, but again, showing that whilst overall the platelet count, or the number of patients who achieved the threshold of 50 increases with platelet transfusion, there's many that don't increment with platelets. And there's also data to suggest that platelet transfusion has other effects. So you can see increased markers of platelet activation. And we know in randomized controlled trials in other settings that platelet transfusion is associated with worse outcomes. So the recommendations from professional societies, as summarized here, there's actually more societies than I can fit on a slide now that have made recommendations in this area. But fairly universally, you can see that for prolonged prothrombin time, no one is recommending to correct this anymore with FFP. The oldest guideline here, the Society of Interventional Radiology, does have a threshold of 2.5, but they suggest giving vitamin K and not to use FFP. And I believe it's currently under revision, so this may change. There's a little bit more variation in platelet recommendations, but it should be sort of an individualized case-by-case decision reserved just for high bleeding risk procedures, based on very limited data. There's even less data to inform correction of fibrinogen, and there's a sort of more professional body saying don't correct, but unfortunately our British one does say consider. So what's happening in the real world? So this is 2 years after the American guideline was published, and in Italy, over 90% of gastro and hepatologists were still using the INR to guide management prior to procedures. And this is a study from Australia, again, suggesting they were still using INR thresholds to inform the use of FFP prior to procedures. So there's a bit of a gap between the evidence and real-world implementation. Some of you might be contributing to the International Patrick survey that HemeStar is supporting, and I think that'd be really valuable to see what we're doing in the UK now. So to finish, there are a number of risk factors for procedural bleeding which do not include hemostatic markers. The most important are the severity of liver disease and the actual procedural bleeding risk. And the ways we can reduce bleeding risk is to defer non-urgent procedures where possible until patients are medically optimized, just as we would in other patients, holding anticoagulant or antiplatelet medications when indicated. We should absolutely not give FFP to correct prolonged prothrombin time. And we shouldn't routinely offer platelet transfusions prior to high-risk procedures, but we might consider platelet transfusions, or I didn't talk about the data for this, but thrombopoietin receptor agonists are also licensed in this setting on an individualized basis with limited supporting evidence. And I'll